syndrome, MERS, the Middle Eastern Respiratory Syndrome, and now this novel coronavirus, so the COVID-19. Either of you, if you can let me know or let our audience know why in particular this specific coronavirus is much more virulent.
So, first of all, in terms of categorization, COVID refers to coronavirus disease, and this is a beta coronavirus like the SARS coronavirus, so it's now called SARS-CoV-2. And the one from 2002 was SARS-CoV-1. And so people, the public, aren't really learning that this is another form of SARS. I think that'd be too confusing, so people are calling it COVID. A lot of people are still calling it coronavirus. So that's kind of what you need to know in terms of nomenclature. This particular virus is actually not as virulent as the SARS-1 was in 2002 or the MERS. The mortality is much lower. It is more contagious. And so you look at the reproduction number, what we call the R0. So if the R, and for an epidemic or an organism to continue to spread, it has to give disease to more than one person from each site. So if you look at the R0 of influenza, it's a little over 1.2 type of thing. So maybe 1.2 people get it from any one person. So it'd be like 6 people get it from 5 who have disease. The classic most contagious one we still talk about is measles, which the R0 is about 12 to 16, which being 12 to 16 people get it from any one exposure. This one is closer to about 2.2. So it's more, it's higher than it actually is for MERS. MERS is actually less than 1. So most of the disease transmission of MERS is still from exposure to camel meat in the Middle East, and that's why it really hasn't gotten out of the Middle East that much, except for that very unusual hyper spreader that's in South Korea a number of years ago. SARS itself, the SARS-1, actually was not as contagious as the one we have now. The R0 was a little lower. It was, I think, 1.5 range, but the mortality was much higher, and the mortality of MERS is about 40%, whereas the mortality of this disease is about 2%. So,
I also wanted to talk about transmission of these of this specific virus. So droplet transmission is what we've been told, and also there's the concern of aerosolization, and then sometimes also for children there's the concern of fecal-oral. Dr. Blumberg, did you want to weigh in on some of the ways that it's different in terms of transmissibility in children?
Yeah, so it's primarily droplet, and then the droplets can contaminate surfaces, and then that could, by contact with the surface, you could get it. But really the droplets are the primary form. It's been detected in the stool, but in terms of its infectivity and if it is, if it's transmitted that way is not known. It's not transmitted through fecal-oral. It's likely not transmitted through fecal-oral because it's not transmitted through food either. But it could be transmitted through contact with the stool. But it's much less than with SARS, the first go-round. In that case, a lot of patients had diarrhea, and in this case, with COVID-19, a small minority of patients have diarrhea, less than 5%. So it's really the droplets that we worry about, and that's why you're hearing about all the 6 feet separation for social distancing, is that the droplets, almost all of them, only can be transmitted about 3 feet with coughing, with a real forceful cough, maybe up to 6 feet. And if you're farther away than that, then gravity takes over and they end up on the ground.
All right. And then, so that also gives leeway into protection of ourselves, staff, and patients, especially with limited resources. So, for example, surgical masks, the N95, face shields or goggles, and the PAPR. For us recently, just a few days ago, we have now new guidelines in terms of when we should be using the surgical mask for ourselves, our staff, and then also our patients. So guidelines such as if you're going to be in patient care less than 6 feet or greater than 10 minutes of patient involvement. Can both of you speak to the importance and what would be kind of hierarchy in terms of using this for PPE for us if we are going to see a PUI or a COVID patient or just our usual illnesses in pediatrics during our clinic time?
Yeah, so if it's okay, I'll go first. In terms of PPE, in general, your facial protection in terms of your mask and your eye protection, and then your gloves are the most important. The gowns are considered the least important in terms of actually protecting you. In terms of the mask, of course, we want a mask. If you were to wear a regular mask and a patient was to wear a regular mask, and you had eye protection on, the actual risk to you is probably not very high. But then in little kids, the population is very different than it is in adults. So getting a kid to comply with that so they don't take it off and don't cough on you is a lot different than when I deal with adults. In terms of, but I'll let Dr. Blumberg kind of come in here before I say any more.
Yeah, no, I would agree. I think the important thing is that for healthcare providers that we want to protect ourselves, and kids, depending on their age, their normal development, their hygiene can be compromised. And so we've probably all had the experience where a kid has coughed directly into our face or even into our throat. And so if you've seen anybody with any kind of upper respiratory symptoms, it's appropriate for you to at least have contact and droplet precautions. And so the droplet precautions would be to wear a surgical mask. And then it's recommended if there's any, you'll see the N95 masks. Those are recommended for if any aerosol generating procedures. And those procedures are things like intubation, extubation, bronchoscopy, stuff that people aren't going to be doing in the office. So the regular surgical mask for everyday use for kids with upper respiratory symptoms would be appropriate use.
Can you guys also weigh into the importance of what type of mask? If we're going to do some swabbing in our clinics, is a surgical mask okay, or do we have to use the N95?
Well, this really gets into the question of what is your risk of getting coughed into your face in terms of the protection, right? Because that's really where it gets aerosolized. So obviously when you're swabbing, you're going to be up close. And in my viewpoint, that would be the time to be considering N95 and eye protection. Now, with that said, we have to kind of look at PPE as practical and doable. So N95 masks have electrostatic charges to the masks, which the regular procedure surgical masks don't. And the importance of that is that the particles actually stick to the outside of the mask and don't fall off. So you can actually go from room to room to room, and your N95 mask is fine. As long as you handle it properly, you can leave it on, and you could, and then just take care of multiple patients and not have to worry about it. So, if you are going to be kind of like in a respiratory clinic equivalent with COVID everywhere, you actually could put an N95 mask on and see multiple different patients without changing that. And then you would just change it, like when you go out to take a break to get something to eat, and then you need to get another mask. Or we're also, well, at a clinic level, that's what you would be doing. The other thing is I need to go back and mention about nebulized therapy, because you do those kind of treatments in your clinics. And there's debate as to whether or not that's considered a high risk of aerosolization. And the SARS article from the critical care units in Toronto, when they had in 2002 range, they looked at what things were risk factors for healthcare workers getting SARS. And that kind of got lumped in there only because it was noted that they were doing a lot of it, not because necessarily that it was a risk factor. Just this morning, I was on a call. We've identified a filter that can be applied to the nebulizer so that you'll be able to do it in the office, because some places are doing it in their cars now, going out and doing pediatrics in the cars with nebulized therapy. So I'm hoping in the next week or so that we'll be able to start making those available, and then you won't have the concerns about nebulized therapy in your office.
That would be great. That was a big concern for many of us in terms of how to do that. In the meantime, what should we be doing in terms of aerosolized therapy for albuterol? Some of us have the ability to have spacers in the office. We have multi-meter dose inhalers of albuterol. Is it safe to give albuterol through one inhaler on multiple patients if they're using a spacer?
Yeah, so we have a common canister protocol that we're developing. It's almost done, and with the cleaning protocol. And John Kakunda from Sutter Pharmacy is kind of your resource, and we talked about that again today, and that's ready to go live in terms of we have to have an appropriate cleaning protocol for sterilization or I should say decontamination, because not really sterile, of the decontamination of the MDI.
Okay. And then
somebody's got their speaker on.
Somebody mute their call, please. All right. So there's also social media on Facebook. Sewing a million masks is kind of the movement. And it shows the communities want to really help us and help us with during this time to help us with our PPE. With these surgical masks that they're making from different types of cloths, I've tried to intervene and say, I'm not sure if we're going to be able to accept that. What is the going theory about that? When I tried to intervene, they basically said, well, something is better than nothing because of the concern of the loss of resources for our masks. Can either of you weigh in on that?
Well, I'll let Dr. Blumberg go first, and then I will.
Sure. The CDC's got a lot of guidance on this in case there are mask shortages, and they've got, I think, 12 different steps depending on what you've tried with the shortages. And all the way at the bottom, number 12, is cloth masks or use a bandana or something like that. If you look at how the cloth masks filter, they filter very poorly. Most of the studies show that it's less than 5% filtering, and so they really don't provide much. I suppose if you're going to have a kid cough in your face, yeah, that would protect your, from getting in your mouth. But, basically I view these things as feel-good activities. It gives people something to do.
Right.
Yeah, so I don't disagree. I kind of view them as an opportunity to give to patients who are in your waiting room. I think a lot of patients and parents, because pediatrics, a lot of people want a mask, and so they get a lot of comfort from you offering that to them, which is different than saying that you, doctor, nurse practitioner, mid-level, will be wearing those masks unless we run out of options.
All right. The other movement is also the making of face shields. So I've seen it on various Facebook profiles with different forms of thin plastic. Are those also usable for our community to make and donate, or with even our children? Some of our children are making that for us as well, too.
I'm going to defer that one completely because I don't know. I really have no data on that one.
The design is similar. To me, I would have more confidence. I mean, plastic is plastic, right? So it should, block a splash. I feel much more confident than that with the homemade face mask.
I do too.
Yeah, that makes sense.
All right, so thank you. I did want to go into symptoms. So, Dr. Silvers, I wasn't sure of your time. You said that you were able to do the first 30 minutes, or Are you still available for the entire talk?
I've got about another 10. I've got another call here kind of pinging me, oh, do you have time? And I just wrote them 10 to 15 more minutes, so I can do another 10.
Okay.
How's that?
Sounds good. Thank you. I just wanted to know the time. So typical symptoms, if we go to symptomology, for the fever, cough, upper respiratory, lower tract symptoms as well, too, with shortness of breath, hypoxemia that we can see. Specific risk factors, so I guess this goes to Dr. Dean. For kids that would increase severity of disease, are these mainly our high-risk groups with cerebral palsy, chronic lung, trachs, that sort of thing?
Yeah, I think they are, but that's all theoretical. I mean, the disease has been extraordinarily mild in kids, and so even that many people might be aware of the pediatrics article that came out, over 2,000 kids reported from China, and it was a little bit confusing to interpret, but of those kids, 90% of those kids that they reported had mild, moderate, or asymptomatic infection. And the way I interpreted that when you looked at their criteria is those would be outpatients. And of the 10% of patients that were admitted, 8% would have been floor care, in my opinion. They just needed something like supplemental oxygen. And 2% would require ICU level care. So it's extraordinarily mild in children compared to adults. I'm really fearful when this hits hard is what it's going to hit. It's going to hit adults, it's going to hit grandparents and parents, and that's how it's mainly going to affect families. And then it's going to affect us. It's going to affect healthcare providers, doctors, nurses, and anybody who works in the hospital, respiratory therapists and stuff. So I think that's where it's going to hit the most. We have these theoretical concerns for kids with comorbidities, but I haven't seen any data that show, for example, that kids with asthma are more severely affected than kids who don't have asthma. But those are the usual risk factors for severe respiratory infections.
It is pretty amazing. And pregnancy is another one that it doesn't seem to be doing damage like you see with other viruses. We talk about preterm labor risk and stuff like miscarriages and stuff like that. Not a lot of data saying that.
Okay. What are the going theories out there as to why kids are asymptomatic or mild moderate disease in severity?
I don't want to make up a story.
Yeah, I'll start with that, which is, in my limited understanding of immunology and the developing immune system, I think of other diseases like hepatitis A, for example, where kids are completely asymptomatic or might have loose stools for a couple days, or EBV infection, which is very mild, West Nile infection. Kids hardly ever get it, and if they do, they're almost all the time asymptomatic, and so that's really. The older you are, the more severely affected you are by those infections. So I'm not sure if it has something with the developing immune system. There's some evidence in adults that it's the dysregulated immune response to infection that results in the ARDS that may develop. And then others have postulated that maybe it's a prior infection, like with dengue, for example. The first time around is mild, and once you're primed, the second time you're exposed to something, that it can be more severe. So those are the theories that seem to make the most sense to me.
Yeah. So I have to tell you, as we're going on both sides, I don't actually think those theories make much sense to me, to be honest. I understand them, and the reason I say that is because it's up to the age of 20. They really don't get very sick. And the other thing is pregnancy, which alters the immune system. They don't seem to get very sick. So, and we haven't seen the patients with lupus, for example, get sicker than other people. It's maybe a little, but it's not dramatic. And we're even talking about, heart, lung, kidney disease. People throw in liver disease. I haven't seen as much data on that. Immunosuppressed. I haven't seen as much data on immunosuppressed either. We throw it in because these are risk factors. I think what you're saying makes some sense, and I think it just shows that we have kind of a limited understanding and to really know for sure.
Okay. And in terms of long-term or future concerns for people or kids who have recovered from COVID disease or other virulent strains, anything that we as primary care should be looking out for?
Well, there is.
I'm not aware of anything in children. I haven't seen any kind of long-term data. Of course, it's only been around for a few months, but in adults there's some, and I'll let Dr. Silvers talk about that.
Yeah, it's interesting because it feels like it's long-term that we've had this because we're living it 24/7 now, but it is only a few months. I mean, it's only really 3 months of true information about this infection. And so it's really hard to say, but there are people who are talking about delayed recovery of lung function as at least symptomatically are a lot of the measurements in terms of people saying that they can't walk a flight of stairs like they did. They get shorter breath. They just get more winded easily. But again, it's still short term. So I don't know what it's going to be 6 months down the road. Are we going to have people get interstitial pneumonitis, for example? I mean, I don't know. We'll see.
All right. I'm going to move on to testing. There are tests out there from Quest, LabCorp. We also have our public health tests. We are all kind of within our organizations generating point-of-care tests. But what we don't know in ambulatory care is the sensitivity of these tests. We've heard ranges of 40 to 50%. Is that true, or what? Are they all the same? Are they different? What are we doing?
You want to go first? You want me to go first?
I'll go first with it. There are different tests that are being done. So I know that the tests that are being done at UC Davis and Public Health are different, and they're changing by the moment. So there's different tests being put online. I know that Sutter's been online for a few days, I believe, the in-house testing, and they do have varying sensitivities. I think the worst test is the one that was rolled out by the CDC, which was reported to be about 60% sensitive. But the current ones, the most recent ones that have more rapid turnaround time and that hospitals are doing, have sensitivities of greater than 90%.
That sounds great.
Yeah, so really, when you look at these tests, you're looking at primers. They take a particular part of the organism that they separate out and then reproduce in the specimens to see if it's present. And depending on the primer they chose and whether it mutates and stuff, it will change the sensitivity of the test. So some of the stuff coming out, first of all, I don't know what primer they used in China, or they're still using, but they were reporting 30-some-odd% to 70% in their different articles. Now, what you need to also know is that, because so much is being published, many of the articles we're seeing have not undergone the scrutiny of peer review that they normally would undergo before they get published in these journals. And there's a lot of really kind of mediocre studies out there with lots of type 2 errors with small numbers of people being tested and ... The CDC primers are a little better than the WHO. The CDC, when I heard them on a call, they said their test was 95% sensitive. I don't think it is. The Quest was using I don't know which platform they were using, but now they've gone to the Roche platform. The Roche platform is significantly more sensitive than the CDC, and there's other platforms kind of in between. I don't know what the number is, and there's a lot of concerns. I don't actually believe that it's in the 90s at this time. I mean, some of it has to do with the quality of the specimen collection, because you really need a good nasopharyngeal, or in your case, maybe sometimes a good oral pharyngeal, and then processing in terms of handling the specimen, and then it depends on how long the person's been sick, because if viral load decreases after a week, it progressively decreases, and so the threshold for measuring positive test gets influenced. I don't know. If I was to guess, I actually think it's probably closer to about 80. than 90s today, at least for what I'm seeing in the hospitals. And I'm basing that on people with negative NPs who are having CTs that show very typical ground glass opacities.
Dr. Blumberg, did you want to add on?
No, I think Dr. Silver's did an excellent job of sort of explaining how complicated it is to deal with these emerging infections where information is coming out all the time and it's coming out in a real haphazard manner.
Yeah. So I know that initially, at least in our office, when we were, considering COVID-19 in one of our patients, the public health asked us to do serum testing. So my question is there also an antibody titer that we should be looking at to maybe kind of not over-fatigue PCRs?
So I'll answer that because then I have to get off and go to this other call, if that's okay. So there is a IgM test coming out. It's $10. It's a drop of blood, finger stick, 10 minutes. Get your answer. So that's what they're going to be promoting. You have to understand that IgM takes probably at least 3 to 4 days of illness before it becomes positive in most patients. I mean, so you could, if you did it too early, you could have a false negative there. IgM stays positive for several weeks at least, and then the IgG kind of kicks in. I don't know of any IgG test. I know the CDC has stopped asking for serum, and so it's really. I don't know that we're there yet for acute disease, but I would keep your eyes on this IgM test that may be coming. That's supposed to come out soon.
All right. And Dr. Blumberg, anything to add in terms of the IgM for pediatrics?
Yeah, I mean, it would be great, but again, we haven't seen anything in terms of sensitivity, specificity, and IgM tests are notoriously difficult with a lot of false positives. So I don't know where they're going to how they're going to balance that in terms of sensitivity.
I agree completely. Okay, I'm going to step off. Thank you very much, everybody.
Dr.
Take care. Sure, bye-bye.
All right, so we're going to continue with Dr. Blumberg. So, Dr. Blumberg, I wanted to segue into medication. So we talked about albuterol, but there are also other medications that have been, put out there in terms of what we were reading in the literature, also in the public. NSAIDs and prednisone. Can you address that? Does that prolong viral replication? Does that make things worse?
Yeah, the NSAIDs, that comes from studies that people may be familiar with a few years ago from Europe, from Poland, that showed that any kind of anti-inflammatory decreased response to routine immunization. And then there's been some studies that, conflicting studies with that too. And I think some people, including in France, the public health authorities, kind of took that a little bit too far, in my opinion, by saying that people who have this shouldn't take NSAIDs. I think it's a theoretical concern. I haven't seen anything that shows that people who take NSAIDs actually have worse outcomes. With prednisone, you could imagine that would happen, that might lead to increased viral replication. On the other hand, with ARDS, we know a lot of that is the immune component, so I don't know where the balance is. So I'm not recommending any kind of change in practice regarding NSAIDs. If people have a fever due to COVID-19 and they want to take ibuprofen or acetaminophen, then go ahead and do that. I'm not making any recommendations against that. And if asthmatics need prednisone to control the wheezing, then they should have that.
All right, thank you. And then to segue into treatment studies, so earlier on, Dr. Silvers was talking about the remdesivir. There's also hydroxychloroquine that's been out there, plus or minus in combination with Zithromax. Is there studies going out in kids to see if, for moderate illness, are any of these worthwhile? And can we use them not just inpatient but outpatient?
Yeah, so there's a lot of studies going on. I haven't seen any results in kids. The studies that have come out and related to adults are very small numbers and have significant methodologic problems, so they're very difficult to interpret. So if you hear reports about them in the media that something is good or isn't good, I would caution you that if you go into the details of the study, you might have a different opinion on that. Those are really preliminary findings. The remdesivir is an antiviral that was developed for Ebola. It does have broad antiviral activity. Right now, that's probably the best option for severe disease. It is not available anymore from the manufacturer. It hopefully will be available soon for compassionate use in children. Chloroquine and hydroxychloroquine have broad antimicrobial activities, including antiviral activities. In vitro, they look very effective against this virus, but there are but the clinical studies are very preliminary with adults. They do show a decrease. They suggest a decrease in viral load, so they are being used for inpatients. You can't get these anymore at outpatients. There's been a run on them because of a lot of publicity about them, so I don't believe that you could get these anymore. And on inpatients, they're severely restricted to infectious disease approval also. And azithromycin, since there was recent publicity about that has been used in combination with chloroquine or hydroxychloroquine. Again, really conflicting information coming out from the preliminary studies, but that's another one that now is being reported to be in shortage because people are so scared and they're hoarding it. So that's one that's also, if it's not already requiring ID approval for inpatients, it will soon.
Okay. And I also read about convalescent serum from those that have recovered from mild moderate disease. Is that also being investigated in kids?
Yeah, I'm not aware of that being investigated in kids, but I have seen the news reports that it is being used in adults. And, theoretically it might work, and theoretically it might make things worse because, again, once the patients are severely ill and they have ARDS, a lot of the severity of illness is not due to the virus being pathogenic or cytotoxic to the lungs. A lot of that is due to dysregulated immune system. So you may have also heard about another treatment, and I can't remember the name, but it's one of the monoclonal antibodies that's used for autoimmune diseases. And that one, there's some preliminary studies showing that one looks promising for severely affected patients. But yeah, the convalescent serum, just as an aside, I think it was the movie Outbreak with Dustin Hoffman that he heroically saved his ex-wife's life by donating that. So it's really heroic stuff that we're talking about.
Okay. I'm going to stop here and I'm going to open it up for question answer. You can unmute. You can do *6 or just unmute your phone if you can, and go ahead and ask questions to Dr. Blumberg.
Hi, Dr. Blumberg. Kim Bernyson from Sutter Davis. I have a question. So I understand lots of studies, things going on. Well, who would you recommend that we test outpatients? Because obviously we have limited tests. Right now the Quest turnaround is 8 to 10 days, which is ridiculous. So that's not a usable test in my mind. And then we have the health department, who's obviously, cohorting who they want to test. So the acute care facilities, that's easy. We know that if you're inpatient, you're respiratory distress, it's going to be one of the thought processes. Who should we be testing outpatient for that, and where should we be sending our tests? What's your recommendation? Thank you.
Yeah, so there really is limited testing availability right now, and so we're really recommending testing if it'll make a difference, if it'll make a difference for your care. So obviously a patient in the ICU, we want to know what they have. And we might even want to enroll them for a compassionate use study. A hospitalized patient, we probably want to know because we'll stop looking for alternative diagnoses. On the outpatient side, it would generally be people who might be at risk for more severe disease, if they have severe underlying illness, or if you might do something different epidemiologically, so patients who, for example, reside in residential facilities, because we've all heard of the tragic deaths that occurred outside Seattle in the long-term care facility there. So an outbreak in one of those facilities could really wreak havoc. So it really depends on if you're really going to change something. Right now, with limited testing availability, we don't have that many options. If you have a cold, you want to know, and I know that parents want to know if they have it or if their kids have it. but we just don't have the option for that except to sending to the commercial labs like Quest, and then we have that long turnaround time. Hopefully, in the future, we'll have faster turnaround time. The shared lab at Sutter is online. They're able to process more samples, and we're hoping that they're going to ramp up, increase. I heard that for hospitalized patients, soon they will no longer require ID approval for testing, which shows you that they will have more capacity, and then hopefully they'll have more capacity for outpatient tests also.
Thank you. Any other questions for Dr. Blumberg?
I had a question. Can anyone hear me?
This is Dr. Sherman. I have a quick question. We've been told a variety of different things as far as isolation for patients. I think right now what we're telling them is if they have a strong exposure or they're positive and asymptomatic, we're keeping them home for 14 days. And if they're symptomatic, we're keeping them home for 7 days plus 3 days asymptomatic. What's your opinion on that?
Yeah, so I think if they're symptomatic, yes, they should stay home at least 7 days after illness onset and 3 days after being completely asymptomatic. And I'm sorry, you said if they test positive and they're asymptomatic?
Yes.
Yeah, so I guess I don't know why they'd be tested, but
I don't know either. I guess if they had a strong exposure or high risk factors, you see it sometimes. So that was my question.
Yeah, I don't know what to do because we know that there's people out there in the community now who are asymptomatic or have mild illness, and they're probably positive and they're out there in the community, but they haven't been tested, so we don't know about them. So if they're asymptomatic, I think the chances of them transmitting to others is lower than if they're symptomatic because they're not coughing or sneezing, so they're not producing the respiratory droplets. Still, by talking and yawning, they are able to infect other people. So if you knew that they were positive, you would certainly want to keep them away from anybody that's at high risk for severe disease.
I have Dr. Craig Swanson on the phone, and he had a question. He's our neonatologist.
Hey, Dean.
Oh, I'm sorry, our hospitalist. Sorry, Craig.
Sorry. Just related to the question of PPE, there's a lot of controversy around high flow and PPE. Do you have any clarity on that?
I'm sorry, I don't. I've heard it go back and forth, and I think it depends on the system, is what I've heard. And I don't know much about high flow, about the specifics, but initially we were told that may result in aerosolizations. And then later we were told, depending on the equipment that you use, that it doesn't result in aerosolization. So I don't know the answer to that, and I would ask infection prevention that question.
Okay. And then I got 3 questions. The second one is related, and I think you said this, but I want to be 100% clear. For delivery of albuterol and PPE, what was the sort of bullet point on that?
I actually don't know the answer to that because that was Dr. Silvers was talking about that. And I kind of tuned out because that's not my thing. Sorry.
Yeah. Okay, no worries. And then my last question is kind of a more semi-theoretical question, but I heard that the IgM testing, that you can utilize the old SARS test and it's accurate or works. And if that's true, I'm wondering, do we know if SARS exposure or infection in the past confers any immunity to SARS-2?
I don't know the answer to that. It's an interesting question. I do know that the SARS-1, when that was ongoing, there was vaccine development against that. As soon as that was eliminated, all that vaccine development, nobody funded it anymore because nobody was interested. But when SARS-2 came around, the researchers unearthed those old vaccines and looked to see if they would be effective in animal studies, and they looked very effective. So it looks like the immunity conferred by at least the immunization against SARS-1 would protect against SARS-2. So theoretically, if you had SARS-1 the first time, you'd be protected against SARS-2 also. But that's all theoretical.
Okay. So my last question is just because I'm sure everyone on the phone gets bombarded with everybody's opinions about everything. Do you have any insight into why the CDC test was delayed? Like they said there was a technical problem. Do you know what that was?
I haven't paid much attention to that, but I think part of it was they wanted to develop their own test, and they didn't want to use the test that was developed originally in Germany. In Germany, they developed a test that the WHO quickly said was the gold standard, was the standard test, and that was then exported around the world. And virtually every other country used that except the U.S. And so the U.S. developed their own test. There were problems with that. There were problems with when they tried to scale it up, and that's resulted in a lot of delays in the U.S. And so, we're really behind the rest of the world in terms of testing and in terms of knowing which communities there are outbreaks in and the extent of transmission in communities.
All right, thank you.
I have a question from Dr. Angie Vickers, who is in our child abuse sector. So her question is that if it is low risk for pregnant moms with COVID, why are we separating our babies in the hospital from our COVID positive moms?
So there's two issues there. One is that the evidence for being low risk in pregnant women is based on one preliminary paper that was a case series of 253 women from China. And what it showed was that it did not appear to be any signal for preterm delivery or increased severity of illness. But pregnancy makes us all really nervous, and we're still nervous that it still might affect pregnancy despite that preliminary data. So we're worried about that, and then we're also worried about if the mother's positive, could there be transmission to children? So there's some evidence that there can be limited intrauterine transmission, and we're concerned for postnatal infection. We know for many other infections similar to this that it's the extremes of age that are affected, and so that neonatal infection could result in more severe disease. So it's more of a theoretical concern because I haven't seen any evidence that it is more severe in neonates.
Okay. And then her second question was also what I think we all would like to know. When we run out of the surgical masks, you alluded to 12 different things to go through before going to the cloth mask that our community is making for us. Where can we get a list of like numbers 3 to 11 or the other ones? What are the other ones? We're talking about the vacuum, the ones from like HEPA filter, paper, or anything like that?
So when I put into my search engine CDC face mask, it brings me to strategies for optimizing the supply of face masks on the CDC website. And they talk about, if you scroll down, they talk about contingency capacities. And I'll just quickly go through this. One is remove face masks for visitors in public areas. I think we've all done that. Implement extended uses of face masks, which I know is being done on the inpatient side at Sutter. Restrict face masks to use by healthcare providers rather than patients for source control. And then for crisis capacity strategies, it's using face masks beyond the manufacturer designated shelf life during patient care activities. And we've known, many people might have heard in the news that the governor released some pristinely stored face masks that were beyond use and said we could use those. Implement limited reuse of face masks, prioritize face masks for selected activities, and when no face masks are available, the options exclude healthcare providers at higher risk for severe illness, designate convalescent healthcare providers for provision of care, use a face shield instead of a face mask, consider use of expedient patient isolation, consider use of ventilated headboards, and then all the way at the bottom is healthcare personnel use of homemade masks. So that's the list. Do we have time for one more question, Dr. Blumberg? Sure.
All right. Anybody else have any questions they would like to ask before we end the call?
Hi, Dean. Kim Bernison again from Sutter Davis. For the hospital situation, obviously we'll have mom and babies, and then we're going to have mom to, because we live in Davis, refuse to separate despite recommendations currently from the CDC. And so then we're going to need weight and jaundice follow-ups for these parents. And they're talking about the well caregiver who needs to be the person taking care of the patient. So the newborn, should we be screening the dad or whoever the well, quote-unquote, caregiver who's exposed to this mom, who's a PUI or perhaps COVID positive? How do you promote, like, outpatient visits? Now, obviously we have video visits. You can't video visit a weight or jaundice. And so these are babies that are going to have to come in, and their moms may be COVID positive. Any guidance for the outpatient visits? There's clearly a lot of guidance for the inpatient visit.
Yeah, so for the outpatient, there's two things. One is now I'm losing my train of thought what the two things were. I had this all well organized in my head a moment ago. For the outpatient visits, in terms of the moms, what option they might want to choose is there's three sort of options that are chosen for the mother's contact with the baby postnatally and breastfeeding. And I was just talking with Dr. Gustavo Sosa about that this morning. And, you know, it really is, there's the absence of data. We know that there's so many benefits to skin and to breastfeeding. So really what we're doing is providing options to parents, and I don't think any of those options are wrong. I do have opinions about the ones that I would recommend if I was asked, but I don't think any of those options are wrong in terms of either, you know, anywhere in between having the mother having contact with the child and, like, separating for 14 days. And so they can choose any of those. And then in terms of screening when they're coming back to the office, there's protocols to clear the kids from infection in the perinatal period, so before they're discharged. And then for if the father's bringing the child to the clinic and the father's not infected, you know, it's basically symptomatic screening. We know this virus is out there in the community. I'm sure all of you have seen a patient with this already, whether you've diagnosed it or not because of limited testing. I don't know about that. But I'm sure you've seen patients with this because we know that it's in the community, and we know kids are getting this and adults are getting this. So for the father, you know, it's symptomatic screening. So if he's coughing or has a fever, then he shouldn't be coming in. If he's not coughing or doesn't have a fever, he might be asymptomatically infected, but I guess I don't care as much in that situation. He's less likely to transmit.
I think we're out of time. Thank you so much, Dr. Blumberg, for your time and expertise.
And Judy, thank you for arranging this.
Oh, thanks.
Thank you all.
Very, very welcome. Thank you.